Welcome back. Doctor, let's pick up because we kind of broke that sort of in the middle of a train of thought, and I apologize for that. But we were talking about the use of medications, some that we've known are used in the treatment of depression, and others that, as you were saying, have become useful in the treatment of chronic pain.
Yeah, as I was saying, it's important with these drugs to give it time. There's an old expression in medicine that time in and of itself is a drug. And I think a lot of times when you're in pain, it's hard to be patient, and you want, especially if you've come from the treatment with things like the opiates or some of the non-steroidals, where you do get relief essentially immediately, to be able to say, okay, this is going to take 3 or 4 months. As I was saying before, a lot of times dosages have to be adjusted, increases in dosage, augmentation with other drugs. So really it's a 3 or 4 month thing, and again, it is a background drug. It's not like taking a fentanyl patch or something that's going to give you immediate relief.
You bring up a good point, something I did want to discuss if we could, and that is, do you find yourself dealing sort of interdisciplinary, if you will, like you from the psychiatric standpoint, along with, say, physical medicine or orthopedic surgery or even neurosurgery?
Yeah, absolutely, all the time. I mean, one of the things we often find is that the other doctors will have prescribed other medications, which is not uncommon. Especially we have to be careful with addicting substances, and there is a real danger of patients becoming addicted to opiates after they've had chronic pain. And opiates in and of themselves can be depressogenic. They can cause depression. And sometimes you can get rebound pain where you've gotten so used to the use of opiates that when you start to have them wear off, you actually get rebound pain where it spikes above. Well, this is where some of the ancillary medications like the antidepressants, also things like Depakote, which are used for seizure medications, Tegretol, Neurontin, which are all off-label. Let me clarify that. They're not indicated for pain, but again, they're used for the expression of pain running up and down the nerve ending, because that's where they work. They work on the nerves to control the receptors so that you don't get that expression of pain.
I don't want to leave people necessarily hopeless in this situation, because that's the purpose of our conversation here this morning. Is there what I'll call light at the end of the tunnel for people who are treating for chronic pain?
I think there is and there isn't. I'm not going to lie to you. Very often it is very difficult to treat chronic pain and its concomitant depression and mood disorder. Patients with chronic pain when they become depressed, are irritable, they're short-tempered. In many cases, it affects their interpersonal relationships with their families, because now this real easygoing guy or girl is constantly in pain. Well, think of the last time you had that chronic toothache. You weren't a whole lot of fun to be around. Well, add that times 5 years. So it affects all spheres. It affects your work, your home life, your interpersonal relationships. I think what I like to say is, with patients who have chronic pain, I can usually get the depression under about 70% control. I usually can't get it under 100% control.
A lot of the people who are watching here obviously don't suffer from chronic pain, thankfully. What I'm wondering now is, are there things that they can look for in loved ones or people that they're living with that might help direct that person to seek, say, for instance, treatment with a specialty like your own or another one of the specialties?
I mean, change in personality. That's a big one. Like we said, somebody who was easygoing, jovial, easy to get along with now is irritable, short-tempered. Isolation. I don't want to leave the house. I don't want to be around my friends and family. Something called anhedonia, which is a big way of saying I don't enjoy things I used to enjoy. So again, this is a person who maybe used to love to go to the movies. Now, he could still go to a movie because he's not physically impaired, but he just doesn't want to. That's the depression. Changes in sleep and appetite. Changes in motor function, where they just want to sit on the couch. They don't want to do anything. Changes in energy level. And one thing that's undernoted, changes in focus and concentration. Lots of times patients who have depression and comorbid chronic pain will say that they feel foggy. And the knee-jerk reaction is to think it's the morphine or whatever pain med they're on, which can do that. But a lot of times it's the depression in and of itself.
So the bottom line on that is if you start to see these things, it might be beneficial to suggest maybe seeking the services of a different type of a specialty.
Right, because a lot of time the physical medicine doctors, the guys who do the orthopedics, and even some of the chronic pain doctors, so I'll have to say most chronic pain, like neurologists or rheumatologists who treat a lot of chronic pain, are pretty aware to look for that, but sometimes they're not.
One of the things you and I talked about in our last show, and I'm sure many of the people who are watching don't remember that, but we talked about traumatic brain injury and traumatic brain injury symptomatology. Do you see any meshing of those symptomatologies with chronic pain?
We do, because a lot of times chronic pain is caused by head injury, auto accidents, falls, a variety of different sort of traumatic events. And unfortunately, a lot of times they will have what are called traumatic brain injuries, which don't show up on a CAT scan, don't show up on an MRI. And oftentimes we'll see, again, the mood swings, the irritability, the cognitive impairment, short-term and intermediate memory. I've had patients say to me, I used to be able to do math in my head, but since I had that fall, even though I didn't lose consciousness for a very long few seconds, now I can't do higher math in my head. So we see a lot of traumatic brain injuries. One of the things that we can expect to see, unfortunately, coming back from the different wars that we're involved in right now, is the government expects that there'll be over 161,000 people who will come back with traumatic brain injuries.
From what?
Well, unfortunately or fortunately, our current body armor really is protecting our soldiers in a good way from serious bodily injury. But what's happening is they're getting a series of concussive blasts where they're getting sort of, for lack of a better word, getting their bell rung over and over again like a football player might or a boxer, which leads to these post-concussive injuries. Their head is safe inside the helmet, but unfortunately the brain is rattling around inside the skull. And oftentimes they'll be in 20, 30, 40 of these concussive blasts, whether it be from artillery, an IED, or any number of things. The cumulative effects of those multiple concussive blasts and concussions will lead to traumatic brain injury, which can often lead to these changes we've talked about.
And are you seeing that with regard to some of the people that you're involved with?
Absolutely. I do a lot of work with the vets. I do a lot of work with post-traumatic stress disorder, and we're starting to see a real uptick in the number of TBIs, traumatic brain injuries. Unfortunately, it is oftentimes not picked up until much later because it's not a gross pathology. You don't see it, like the patient isn't drooling on himself and can't remember his name. It's oftentimes very subtle.
We're going to take our last break right now. When we come back, we're going to finish up with Dr. Berger in discussing issues concerning chronic pain, as well as a little more on his involvement with veterans and post-concussion syndrome when we return on You Be the Judge.